Room. This session is titled Update in Medullary Thyroid Cancer Clinical Trials, which we're eagerly awaiting. I'm going to read this again for those that may be joining us for the first time this morning. Dr. Mark Zafereo, MD, is a head and neck surgeon and tenured professor at the University of Texas, MD Anderson Cancer Center in Houston, Texas. He is section chief of head and neck endocrine surgery and associate medical director of the Head and Neck Center. He has served on the board of directors of the International Thyroid Oncology Group and the American Academy of Otolaryngology Head and Neck Surgery, and was recently elected to serve on the board of directors of the American Thyroid Association. His clinical practice focuses on patients with thyroid cancer, particularly patients with advanced thyroid cancer, wherein he leads several multi-center neoadjuvant, thank you, phase 2 clinical trials. Dr. Zafereo is a ThyCa medical advisor. On a personal note, I can say that I've not treated at MD Anderson or with Dr. Zafereo, but I've been around long enough to know many of you who have in our group, and I have seen incredible results that he has produced. And I want to say this, Dr. Zafereo is a very, very, very good friend to the medullary thyroid community. So please help me welcome Dr. Mark Zafereo.
Well, that was much too kind of an introduction. Thank you so much for that. It is a pleasure to be here with the ThyCa and the ThyCa medullary group. Although I know all of the patients in here are not medullary thyroid cancer patients. But we're going to be talking about a clinical trial update for 2024. I guess I'll start with, well, let me just start with these disclosures. I do have clinical trial research funding. Nothing comes to me, it all goes to MD Anderson, so I get nothing of this, but it does help our research funding of these trials. It's Eli Lilly, Merck, and Exelixis are the companies that support clinical trials, and Eli Lilly and Exelixis are relevant to medullary thyroid cancer, which we'll talk about. So I guess before I start, you may see a couple of duplicates of the slides if you were on previously, but I just want to set the stage just a little bit. But the systemic therapy landscape for medullary thyroid cancer is very young. It's in its I don't know if we'd say infancy or maybe just at the baby stage. Definitely, I don't even think we can say it's at the toddler stage yet. So, because it really only goes back to 2011, where the first two FDA-approved drugs, vandetanib and cabozantinib, these are multi-kinase inhibitors, and I think we're all aware of that. So I won't spend too much time on it, but just these were some of the original studies published in 2013, looking at progression-free survival with cabozantinib. And some of the original first clinical trials with specific drugs for medullary thyroid cancer. So this was 219 patients who got cabozantinib versus 111 who got placebo, and looking at the median progression-free survival there in months was 11.2 months, and the 1-year progression-free survival was 47%. So, and then we talk about the sort of the safety analysis and the adverse events. We know that with these drugs, these kind of first drugs that were FDA approved for medullary thyroid cancer, they do have some side effects. Some of you may be on these drugs, but and these are, I should say, even for patients who have RET mutations, these are also potential second-line drugs, right? So these are drugs that you could be on in the future, cabozantinib and vandetanib. For patients who do not have RET mutations, they're more, first-line drugs. But you see, almost 80% of cabozantinib patients had dose reductions. 16% had to stop the drug during the trial. So you see that there is some toxicity associated with that. 80% had to reduce their dose, and 20% had to actually stop the drug. So due to these side effects. So we talked about before that the way that these drugs work is they really target the vascular endothelial growth factor and vascular endothelial growth factor receptor, which it gives its efficacy, but also gives it some toxicity. I mentioned this slide before. I'll just briefly show it again in terms of the selectivity of these drugs is pretty broad. It hits a lot of different receptors, particularly the cabozantinib and the vandetanib. And it has really a lot of VEGF receptor activity, which again gives it some of its potency, but also its side effects. So I did want to, this is a slide, and I'm not able to share too much about it, but the company has agreed to move forward with it, and we're sort of negotiating with the company on the final protocol and the budget for this clinical trial. But so we know that this clinical trial is going to be moving forward, and it'll probably be open in probably spring of 2025, which will be about 6 months from now. So there's a new drug, and you may have heard of this drug. It's called XL092. So, and I'm kind of intentionally starting with drugs that are more broad, for any patient with medullary thyroid cancer. So, we talked about cabozantinib and vandetanib, which those are the multi-kinase inhibitors. Well, XL092 is the second generation of cabozantinib. So some of you may have heard of this. It's kind of like the cabozantinib is the first generation, and XL092 is going to be the second generation of that drug. So oftentimes, not always, but oftentimes if you got a second generation drug, there's hopefully some improvements on the first generation. Otherwise, you would wonder why you would even have a second generation drug. But so I think that's the idea here from Exelixis. But the drug really hasn't been tested well for efficacy or safety for medullary thyroid cancer yet, or for any thyroid cancer for that matter. So that's where we are with this drug now. So there's going to be multiple different studies, I would assume, looking at thyroid cancer and XL092. In the medullary thyroid cancer space, I can say that we're excited about this as a possibility to treat non-RET mutated medullary thyroid cancer, or in the future, it could even be used as a second line agent for patients who have a RET mutation, but then develop resistance or side effects due to the RET inhibitor and have to go on a different drug. So in this particular trial, so I'm a surgeon, so I'm going to be leading a surgical trial with this drug. And again, I'm not aware of every possible clinical trial that may be out there with XL092 yet. Again, this trial is not even all the way through full sort of IRB approval yet, but I can share it with you now because we've gotten approval from the company. So we're looking at giving XL092 for 2 cycles, and these are for patients with these can be local regionally advanced differentiated thyroid cancer, or non-RET mutated medullary thyroid cancer, or poorly differentiated thyroid cancer. So the non-RET mutated medullary thyroid cancer is where I wanted to make sure that in this trial that we had this is an option, and this is why we included non-RET mutated medullary, because we know that this is an area of need for medullary thyroid cancer, for particularly patients who don't have RET mutations. And again, as I said before, but it ultimately can maybe even benefit patients who do have RET mutations as a second line agent, not as a first line, but as a second line agent. So in this trial, we're going to be, for patients with local regionally advanced disease, we're going to be giving upfront drug prior to surgery, and that's how we're going to be testing the drug. So we'll get, some good efficacy and sort of safety data from this trial, which will be, again, opening in the spring of 2025 with this new drug. So that's what I can say about one clinical trial, which we are going to be opening at MD Anderson, and this will be a multi-center trial as well. So we mentioned RET earlier. About 60% of medullary thyroid cancer patients have the RET mutation. We mentioned the FDA approvals for sulpercatinib and pralsetinib in 2020. I briefly talked about how sulpercatinib has little activity against the VEGF receptor, which can potentially help with some of the toxicity, although sulpercatinib still does have its own toxicity. And so this is sort of the safety profile that I mentioned before in terms of sulpercatinib. for high blood pressure, elevated liver enzymes, diarrhea, and really fatigue is the other one, what I would consider the most common side effects. And in this particular study that was published in 2020, 30% of the patients had to dose reduce related to treatment AEs. So basically 1 out of 3. I mean, that's better than 80%, but it's still, there's still 1 out of 3 patients who has to dose reduce. And then 2% have to stop related to treatment related AEs. And so one thing before I, go on, there's been a lot of questions, and there may be questions in terms of like, the second generation RET inhibitors. And I think, some of you may have been on in other talks, and so you may already be aware of this, but just I don't have a slide on this, but the second generation RET inhibitors have been largely disappointing, unfortunately. So we don't really have any good second generation RET inhibitors which have shown efficacy yet in clinical trials. The clinical trial data, that's sort of the preliminary data, it hasn't been published yet, but that's sort of coming forth in terms of the second generation RET inhibitors is not particularly exciting. And so unfortunately, we're not able to look at that as something that we think is going to be a really effective treatment in the near future. But so, we can talk a little bit more about the first generation, which is of course selpercatinib, and this was an ESMO 2022 update. So I'm going to give a little bit more update in a minute, but in terms of a little bit more recent data. But so this is this study on the right side is looking at months from start of response, and you can see duration of regression. You can see at 3 years in this study, which was published by Croix, Sherman, and Worth, again, initially presented at ESMO in 2022, 77% are still responding to drug at 3 years. So that's, 3 out of 4 are still responding to the drug at 3 years. We don't really have longer term data than that. And these are patients who had not been previously on cabozantinib or vandetanib. For patients who had been on previous cabozantinib or vandetanib, the responses are not quite as good. You can imagine if you take a group of patients who had failed one treatment versus those who had never been treated, the group of patients who failed one treatment is probably not going to do quite as well as the group who had never been treated. So, and we do see that play out. If you look at 36 months here, you see about 58% who are continuing to respond, who had been treated with cabozantinib or vandetanib, then went on a RET inhibitor, selpercatinib, and then, at 3 years, 58% were still responding. But I think, the number to focus on for most people, because most people are going to, at this point, are going to be going on selpercatinib, not having been on previously on cabozantinib or vandetanib, is that 77%. So that's a pretty good response at 3 years, continuing to respond, I would say. We do see a substantial decline in tumor markers, as any of you who are on this drug know. I mean, the calcitonin and CEAs drop dramatically, especially the calcitonin. I mean, it often drops, greater than 90% with selpercatinib. We are finishing up this clinical trial, which is neoadjuvant selpercatinib for RET-altered thyroid cancer. We've enrolled 29 of 30 patients, and it's a multi-site study, which I'm leading from MD Anderson. So we should have data on this soon. I think I have a little bit of preliminary data that I'll show toward the end of the slide. And I'm going to skip over a few. This is a little bit of an old slide. We have now enrolled 29 of 30 patients in this trial, so I apologize that I didn't update the number there. But these are some of the other sites that are Hopkins, Michigan, and Ohio State are also open with this. And this is a neoadjuvant selpercatinib. So it's selpercatinib prior to surgery for patients with more advanced disease. We did a little bit of an interim analysis basically about halfway through the trial. We saw that the median follow-up at that time was now we're over 1 year follow-up. At that time was 231 days. And most of those patients had been able to remain off the selpercatinib. So they had been on selpercatinib before surgery, they had had surgery, and they were able to stay off the selpercatinib after surgery. So, and this is kind of what you may see. This was a paper that we published with sort of looking at sort of how selpercatinib affects the calcitonin. You can see when the patient starts selpercatinib, the calcitonin CA goes way down, and then when they stop it, it often goes back up. But then this patient actually restarted it and it went down again. So we looked at some of our responses in this trial. We typically see about a 30 to 35% shrinkage of disease in the neck. These were, I think, our first 13 or 14 patients, looking at how much tumor shrinkage they got, and the median was about 30% tumor shrinkage. This is if we're looking at the RET neoadjuvant clinical trial on the right side. Again, that's our first actually 16 patients. We saw a little over 30% response in terms of tumor shrinkage, and we were also able to meaningfully change the surgeries for these patients. So again, focusing on the RET neoadjuvant clinical trial, the baseline, these tumors were more often very severe disease in terms of the morbidity of the resection. And you can see, looking at this chart, how the surgeries became less severe, more severe, moderate, and mild in terms of surgical morbidity after the drug. And so, this is looking at some specific examples of tumor response. Sort of, we don't have to go through the details of this, but sort of showing on the left it's pre-treatment, on the right it's post-treatment, and how the tumor response allows us to get the tumor shrinkage. This was about a 40% response in this case, and to facilitate the surgery. Again, another example in terms of a big lymph node that was in the lateral neck that had a significant shrinkage of disease. Also, you see the calcitonin there drop from 1366 to 28 after starting the drug. We do think this neoadjuvant therapy for RET-altered thyroid cancers is a good approach for patients with local regionally advanced disease. And we'll have the full results of this clinical trial. Again, we have one more patient to enroll, which I think is probably going to be enrolled in the next month, and then we'll have data in 2025. We also, I think I mentioned that we have other new TKIs with potential lower side effect profiles, which are under study. I mentioned that in terms of the XL092. I think that will be an interesting drug to study. And although we'll be studying it in the neoadjuvant sense, it will give us a lot of data in terms of how medullary thyroid cancer patients are going to respond to the drug, and then what their side effects are going to be. So we will hopefully be able to share a little bit of data on that with you next year. So I did want to spend the last few minutes, and we'll have questions going over. This is the latest. So this was presented at ESMO 2023, looking at selpercatinib versus cabozantinib or vandetanib in RET mutated medullary thyroid cancer. So looking at comparing the two drugs. So this is a phase 3 study, and this study was actually closed early by the company, by Eli Lilly, because they were seeing very good responses. And I think at this point, it's become very clear that selpercatinib is kind of the first line therapy for RET mutated medullary thyroid cancer. But so I'm going to skip through some of the background, but this is the way this clinical trial was designed, is that patients would either get selpercatinib or cabozantinib or vandetanib, and it was designed as a 2-to-1. 2 patients would get selpercatinib for every 1 patient that got cabozantinib or vandetanib. And if patients progressed on the cabozantinib or vandetanib, they could cross back over to the selpercatinib group. So that's the design of the trial. And this allows you to study patients that are on selpercatinib and compare them to patients that are on cabozantinib or vandetanib. And it was a global study. It was 291 patients from 176 centers in 19 countries. So, and ultimately ended up with 193 patients on selpercatinib and 98 on cabozantinib or vandetanib with that sort of 2-to-1 ratio. So this is, we're not going to go through all this data, but this is sort of looking at basically all the characteristics of these two groups and their age and sex and race and type of RET mutation and kind of showing how similar these groups are in terms of baseline. And this is this is where we saw the comparison. So you can see basically at, if we pick a time, let's pick 24 months there, which is 2 years. And we see, progression-free survival in the selpercatinib group is about a little under 70% there. So sort of similar to the other data I showed earlier, where it was, I think, 77% at 3 years. Whereas with the cabozantinib vandetanib, it was, progression-free, was only about 30, looks like 35% at the 2 years. So it definitely has given us a significant improvement for those patients who do have the RET mutations. And then I'm going to skip this slide. This is in terms of treatment failure-free survival, another way of looking at it, pretty similar to the other slide we showed in terms of progression-free survival. Looking at 2 years, it's about a little under 80% for selpercatinib, and it's around 40% for cabozantinib or vandetanib. And then this is the sort of overall response rate was around 70% for selpercatinib and about 40% for cabozantinib or vandetanib group. So this just sort of solidifies, this was presented at more recent data, it solidifies, the first line indication of selpercatinib for RET mutated medullary thyroid cancer. And this is, again, this is the overall survival on the drug. So, for example, for this particular analysis, it's probably only really relevant to look at 2 years. So, you see the overall survival on selpercatinib is over 90% after 2 years, 90, it looks like 93, 94%. And then in the cabozantinib or vandetanib at 2 years, it looks like it's about 84, 85%. So so that's kind of some of the latest data we have. In terms of safety, there were more side effects in the cabozantinib or vandetanib group. About 76% of patients had grade 3 adverse events, whereas in the selpercatinib, it was about 50%. The dose reduction in the selpercatinib group was about 40%, as opposed to the cabozantinib vandetanib, which was more in the 70%, 75% range. And then those that had to discontinue the drug, only 5% of selpercatinib patients had to discontinue the drug versus 25% of the cabozantinib vandetanib. So I think, this really solidified selpercatinib is in terms of efficacy and side effect profile as being the ideal drug first line for RET mutated disease. I think that's about all that I have in terms of a 2024 update. I do have to say, I'm not happy to answer any questions. I do have to say that I am excited about this XL092. I think that's in terms of, what I can see as sort of the next couple of years in terms of effective drugs for medullary. That's probably going to be number one on the list in terms of what is going to be kind of new out there. We've been a little bit disappointed again about the second generation RET inhibitors. It's still possible that there may be other drugs that we would see as second generation that would be in the pipeline in the future, but it doesn't look like the initial second generations are going to work out to where they're really going to be able to be marketed as drugs for medullary thyroid cancer. So that's where we are, clinical trials in 2024, and I'm happy to answer any questions.
Doctor, let's start with a couple online questions, both of which are condition specific. Anonymous attendee says sporadic MTC with 918T mutation diagnosed October 2023. Response to Retevmo only effective 6 months. Disease now progressing, seems much shorter than trials. Thoughts?
Yeah, well, that's exactly right. So, I mean, we just showed the trial data. So the response in these clinical trials was, at 3 years, basically you see about 75% or more still responding. So, compare that to, 6 months and progressing, that's not an ideal result. So that reflects, you know, a something that we're not seeing a whole lot of, but unfortunately, there's a whole spectrum in terms of medullary thyroid cancer and a spectrum in terms of responses to drugs, and so there are some patients who it's a minority, but who don't respond well. That's a tough situation. Um, I think that if you're ultimately having resistance to selpercatinib and you're not responding to it, you may still stay on it for some time because it still may be the best option. But at some point, if you're really starting to get significant progression, then you're going to have to move to a different drug, which is probably going to be initially it's going to be cabozantinib or vandetanib. Um, uh, we may have an option of this XL092 may be an option in the future if the clinical trials work out well for that drug. That is a challenging situation, and you're going to be back at this point. You're going to be back to the cabozantinib or vandetanib is the second line drug in that case.
Thank you. Next question is regarding XL092. Would this be beneficial for non-RET MTC that has metastasis to level 3 lymph nodes, nodule size of 0.8, elevated calcitonin from first surgery 8 years out, nodule on vocal nerve, surgeon wants to wait until after 1 centimeter? I am good with that, but would this med reduce the size of that nodule?
It probably would, but I don't know that it would reduce it in this particular case enough to change the surgery. I don't think I would recommend going on this drug in that particular situation. I mean, you've got a relatively small burden of disease there, and it just sounds like it's in a bad location, which is why it's being, monitored. We talked earlier about how when you have sub-centimeter disease, you're typically going to monitor that disease rather than, operate right away. I don't think the drug in that case is necessarily going to change that.
Another online question. Is there any data about blending selpercatinib and vandetanib?
No, those drugs have not been combined. I think the toxicity would be pretty high, but no, there's not. I've not seen any data on that.
One more online question here, and we'll hit some in the room. I may have missed it, but does selpercatinib target RET fusions as well as RET mutations?
Yes, it definitely targets RET fusions. RET fusions are not applicable to medullary cancer because with medullary, we only see RET mutations, but RET fusions we see in differentiated thyroid cancer, papillary thyroid cancer. We also see it in anaplastic thyroid cancer. So, it works very well for RET fusions. And that's also, what we see in lung cancer is RET fusions, and it works very well for lung cancer patients with RET fusions.
Secondary question on that topic. Also, generally, what percent of RET-driven MTC are fusions versus mutations?
0 are fusions. So for MTC, it's all about mutations. It's not fusions. Fusions you see again with papillary thyroid cancer and rarely with other types of more aggressive like anaplastic cancer. So with medullary cancer, it's just mutations. And sometimes you see RET deletions with medullary cancer, but you don't see fusions.
Hi, sorry, it took me a minute. A question about the XL092. If it happens to get great results, would there be a possibility to get a fast track for next line for those of us that have already had surgery and failed treatment without having a brand new trial Do you know what I'm saying?
Yeah, I think initially, as this drug's being rolled out, initially, it will have to be, patients will have to be treated on it on clinical trial. So I don't see in the next year, at least, and maybe 2 years, to be honest, if I'm being, really realistic, I don't see this being on the market, right? So, but there will be clinical trials available so that if you do have, um, if you do have uh, resistance to other drugs, there will be clinical trials that will be coming out. I'm very hopeful that we'll have the opportunity to enroll medullary thyroid cancer patients. I included medullary thyroid cancer patients in this trial very intentionally, and I'm assuming there will be others. Given that cabozantinib has an FDA approval for medullary thyroid cancer, um, I would imagine that would be a prime target for any studies that are looking at XL092. Medullary is not as common as differentiated cancer, so you know, uh, I think that these trials will also be looking at differentiated thyroid cancer, but hopefully they'll also include medullary.
I have two questions related to non-RET patients. We have a couple people in the group, or at least a couple people in the group who are non-RET, who are having distant metastases and struggling. And if I understand correctly, the XL092 trial, at least the one you're doing, is only available to people who haven't yet had surgery. Is that correct?
This trial, yes. This trial. Now, I'm not the only one who's going to be looking at doing clinical trials with this drug, right? So I am not aware of other trial concepts and how far along those are. There's none open right now, but I would imagine in the next year or so, year or two, uh, probably between 1 and 2 years, there will be other trials that will be available. It's probably not going to be in the next, within the next year, but a little bit beyond a year, probably you'll start to have trials that have that as an option.
Okay, thanks. And then secondly, looking at the data between like selpercatinib and cabo and vandetanib, for RET patients, you see how much better selpercatinib is. I'm curious if there data with respect to cabo and vandetanib, how the response rate is with RET patients versus non-RET patients, and with the specific different mutations.
Well, I mean, I guess the data that we would have, uh, so we do know this. So we do know that, for example, this phase 3 clinical trial that we do know that, so if we're just looking at progression-free survival, for example, these are all RET mutated patients, right? So they have to be RET mutated. So we do, in a RET mutated population, so this is 98 patients who had a RET mutation. They're treated with cabozantinib or vandetanib instead of selpercatinib because it's a clinical trial, right? Now, going forward, that's not going to be the way that patients are treated, but because it was a clinical trial, it was a randomized 2-to-1 for selpercatinib versus 2 for selpercatinib for every 1 with cabozantinib or vandetanib. But so for the cabozantinib or vandetanib group, that's where we see about a 40% progression-free survival at 2 years. So we know that that's the data for RET mutated patients who get on cabozantinib or vandetanib. I mean, and that's patients who have not been previously treated, right? So if you've been previously treated with a RET inhibitor, that data may be a little bit different. We don't have that data. So the other piece of data we have looking at sort of older trials is all comers, right? So these types of trials, let me just show this. So this is cabozantinib, looking at progression-free survival. I mean, the furthest out that this particular trial, let's just look at a year, because when you get to 2 years here, the data is not as good. But at 1 year, your progression-free survival's, a little about 50%. So, and that's for all comers. Those are RET mutated, non-RET. So we don't have a non-RET mutated only group, I think, at this point to look at in terms of data. But we do have a RET mutated group, which is this new data that came out. Now, these are untreated RET mutated data, but we see, again, 2-year progression-free survival is about 40% in that group on cabozantinib or vandetanib.
Well, I guess comparing apples to apples more, I'm looking at 1 year, and 1 year it looks like it's above 60. And I'm not sure how much you can compare these two studies, but it looks like it's around 60 something percent at the 1 year mark versus 50 in the larger.
Yeah, I
population.
mean,
So
yeah,
I don't know if that suggests-
there may be a signal there, but you wouldn't be able to, statistically, you wouldn't be able to prove that at this point. Yeah.
I think it would be helpful for non-RET patients I guess I don't know what you do with it, but just to know if those drugs are effective for non-RET patients.
No, they are effective for non-RET patients. Yeah, they are. Yeah, we do know that they're effective for non-RET patients. Yeah, I don't think we know. I don't think we really know. There's not been a good study that's looked at cabo and vandy and differentiated by RET status. We can only kind of, look at the data we have. But yeah, it's a good question, but we don't have that data.
There was a new trial starting up, and I can't recall where, but it was associated with CEA, cancers that exhibit CEA. And if I recall correctly, it would be something where you can get these types of cancers to express themselves such that they would be treatable by radiation, where MTC is not, because it doesn't respond. Yeah, I don't know if you know what I'm talking about. And
I don't know if that trial was the NIH or I'm not sure. I'm not familiar with that trial offhand. To be honest, I'm not familiar enough to be able to comment on it. I mean, there's a number of, trials like that, there's also, CAR T-cell trials that have been, studied, for some medullary thyroid cancer patients. And none of those so far have shown enough efficacy to really be able to say that there's a good signal there. But I think it's good that we're continuing to different centers are continuing to study things, even if they may be, a little bit of a long shot. I think it's good to study them because, eventually we'll hopefully hit something there.
So my question kind of has two parts. When you mentioned the phase 2 trials being somewhat disappointing data right now, my question is EP0031 one of those trials? And if so, at what point would it be beneficial to even start considering some treatment to selpercatinib or something different?
Which one is EP0031?
It's the ellipsis, and I'm pretty sure it's a phase 2 trial.
Yeah, but those patients have already failed first line selpercatinib. I think many of them.
So my husband's on the trial.
Uh-huh.
He had a partial response followed by slight progression recently.
Right. So I'm sorry. So you were on selpercatinib first?
No.
You were
First.
never on selpercatinib.
Correct.
You only were on the second generation. You never went on the first generation. So for the second generation, you've had a partial response initially and then progression, correct? Slight progression. Yeah, but you're still on the trial. Yeah.
Currently.
Yeah. Yeah. Well, I think, that's certainly selpercatinib is going to be an option for you. Now, whether or not, I don't think we have enough data at this point to know, like for patients who go on a second generation and then they go back on a first generation, did any of those patients see a response? I mean, it's possible. but we don't have that data. But I think as soon as, hopefully this will be a long time, but if you were to have enough progression on that clinical trial, eventually you would be recommended to come off that drug, and that would be the point where you would, we would say, okay, well, let's try selpercatinib because you haven't tried that.
Right. And
So
that's kind of what we were already thinking. We were already kind of
Yeah.
thinking that it might be time to consider something else at least. Get
Yeah,
something going.
I don't think there's a rush there. I don't know. I mean, I would, there aren't, I mean, certainly this is a question for the doctors. I don't
Right,
have all
right.
I don't have all the details the oncologist does in terms of your particular case, but, there aren't, there's limited options out there, right? So there's, you're on a second line drug, you can go to try, excuse me, then you can try, cabozantinib or vandetanib. So the thought may be, well, as long as it's not, it may be a little bit of progression, but, I can't, it's a little bit nuanced in terms of exactly, when you would switch. But it may not be like right at the first sign of any progression. You may kind of wait a little while and then before switching, because once you switch, you're never going to go back on that second generation drug. That's you're kind of like, so whereas you still have these other options in front of you right now. So
It's something to consider and think about.
yeah, it's something to think about for sure.
Thank you.
Our daughter has been on Vandy for 5 years with a good response, stable disease. How do we know when to switch to selpercatinib?
She has a rep mutation.
Don't have an
assuming?
answer on that. I'm
Yeah.
assuming she's on, I'm sorry, she's on Vandy's. Yep, so we don't know that.
Yeah.
Aletha, if you want to pop in an answer there.
Yeah, I mean, if she has a rep mutation, then I think probably, it's like,
Yes, she has a yes.
it's
a
kind of
yes, she has
the
a-
adage, like if something's working, don't mess with it. It's like, I think it's probably in that case, I would ride the vandetanib as long as possible. And knowing that you have the RET inhibitor as a backup. But yeah, I wouldn't.
And since she is, Aletha has confirmed that she is RET, so she does have a
Yeah.
great backup, right?
Yeah, she has that as a backup option, but I think that's probably why the doctors are not recommending switching right now, because the vandetanib's working. If it wasn't working, or if she was having side effects from it, or that would be a different matter. But
Is there a blended CAR T and RET inhibitor trial? And if so, can you discuss it?
not that I'm aware of. No, I'm not aware of that. But that would be a good question for Cohen.
Yep, let's anonymous, hopefully jump in with Dr. Cohen today and maybe we can get that one out there again. All right, Kristen online says, when I was diagnosed with MTC, I had been living in Turkey. In Turkey, there is a very high rate of thyroid cancer, but I'm not sure how widely publicized prevalence is in the population. Do you know if there are any trials being done out of places like Turkey, or strong partnerships developed between US-based doctors and others?
So I'm not aware of any particular clinical trials in Turkey. But, I am sort of aware that a lot of these clinical trials that have been done, I mean, we just showed a slide of this phase 3 trial, for example, selpercatinib versus vandetanib, and it was in 19 different countries. So I know a lot of those countries are going to be in Europe. I don't know that this trial was open in Turkey, but certainly for these large trials, oftentimes, they're often open globally, including Europe and Asia. I'm just not familiar if Turkey was included in any of these trials.
Here's a good question, doctor. How is it established what most effective dosage of selpercatinib is? Are there studies about that? I hope that a lower dose than 320 mg is as effective because the side effects are less severe. I'm on a lower dose of 240. Is it helpful to get a higher dose in case of resistance? So a few questions loaded there.
Yeah. Well, usually the way clinical trials work is there's a phase 1 trial. So you got phase 1, phase 2, phase 3, right? So phase 1 is the safety and the dose efficacy. So it's so that that dosing of selpercatinib was determined in phase 1 trials years ago, and those were lung cancer patients and thyroid cancer patients. I'm not intimately familiar with the details of those trials offhand, in terms of how how it was arrived at the current dosing of selpercatinib, which is the BID dosing. But that's where that would come from, the phase 1 trials.
We know that this is just relative, and I mean, you only know exactly what is out there now. If you had a crystal ball, I mean, do you have certain areas you're looking towards that might be avenues for next generation? I mean, is there certain, I know, other cancers or other types of,
Yeah.
I don't know what I'm trying to say. Like,
Yeah.
But what would be like on the horizon that's 5 years out or something you're looking towards?
Well, there's a lot of drugs that are in the pipeline right now for cancer in general, that are sort of, there's different sort of, there's antibody conjugated drugs, there's different types of drugs that, not immunotherapy, but they also other types of drugs that affect the immune system. So there's a lot of different types of drugs that are out there that are kind of first being looked at in phase 1 trials. I mean, sorry, phase 1 and then ultimately phase 2, like broad trials, that are kind of covering a lot of different cancer sites. And I think, we will continue to be looking, toward those trials and seeing if we have, thyroid cancer, including medullary thyroid cancer patients who are responding to those types of drugs, because, medullary thyroid cancer is rare enough that you're not gonna, other than the RET, sort of target, there's not really another targetable mutation that's, out there right now. I mean, RAS is always, some of these are RAS mutated, and RAS is a tumor that's been associated with a lot of different types of cancer all over the body. And so there are different types of RAS mutation drugs that are in like broad, what are called basket phase 2 trials right now, that are looking at like, all over, treating tumors all over the body. And you can enroll, medullary or other thyroid cancer patients in those trials if you have that, a KRAS or an NRAS or an HRAS mutation. So we'll be looking, to those types of more broad drugs that are either, mutation specific. Again, the RAS would be something that would be helpful for medullary because, there is a subset of medullary thyroid cancers that have RAS. And then, I think, there's other drugs that are not mutation specific, that will be targeting broadly cancers, and we'll be looking, for example, at MD Anderson, we have these big basket trials that you can enroll patients from all different disease sites, and looking to that to see if we get any signal in thyroid cancer, or medullary thyroid cancer, because that's often where the first signals come from, is these more broad basket trials. And then if you see good signal there, then you can get a specific trial in a thyroid cancer or a medullary thyroid cancer that with that particular drug.
Is there such a thing as a drug that might target the parafollicular cells, since that's the cell it all arises from?
It's a good question. I'm not aware of one. I'm not aware of, I mean, it arises from the parafollicular, the C cells, but once it's arisen, it's kind of, it's kind of diffusely in the thyroid. So, I mean, unless you were going to try to use that to target the C cells in like a hereditary patient who didn't have it yet, would be something, but I'm not aware of anything like that. It's a good question though. It's a good thought.
Thank you.
How many potential years? can selpercatinib work for a patient before resistance can happen? In other words, could it work indefinitely?
Yeah, of course. Yeah, it could work indefinitely. I mean, right now, we just showed the 3-year data that shows 75% responding at 3 years. So, now that number is going to drop, if you go out to 5 years or 7 years, that number is going to continue to drop a little bit, but you're definitely going to have patients who are 10 years out and still responding. Definitely. I don't know what that percentage will be at 10 years. I don't know if it'll be 50% or if it'll be 30% or I don't know.
You expect it to happen?
Yeah, no, I think there will
That
be.
answer's going to make you.
Yeah,
very
well,
popular.
I mean, so yeah.
All right, here's a question. I had transaminitis on selpercatinib, now on 120, and calcitonin between 20-30. Highest before surgery was 250. Had a 4-centimeter tumor with 25 out of 95 nodes positive. Would you go back up again or stay at 120?
I guess I would want to know. I don't have all the information here in terms of why selpercatinib was started in this particular situation. It sounds like the pre-surgery calcitonin was 200 and something.
Let's see.
Is that I mean
Highest before surgery was 250.
250?
Now it's
That's not
between
very
20 and
high.
30.
So I'm not completely. I don't have the whole picture there. I don't know why the drug was started. If there's distant disease that's being targeted there. I think we're still at a point where we're not typically starting selpercatinib, just kind of electively for, just to kind of prevention. We're kind of using it. There's 2 situations. One is if there's structural disease, distant disease that's progressing, right, is one reason why somebody may need to start it. Another reason is, if you presented with really aggressive bulky disease and you wanted to shrink it before surgery. But I'm not, without being intimately familiar with why the drug was started in the first place, it's hard for me to comment on, like, would it be okay to decrease the dose or something? Because I don't know why that drug was started in the first place. But, I think we have had patients who decreased their dose of selpercatinib and they're still having good response. And so I think a decreased dose is okay. And it still works for a lot of patients.
Couple more here and we'll let you get about your weekend. With the broad basket studies answer that you just discussed, are you aware of other cancers with RAS mutations that we should look at? And I'm assuming what they mean are other cancers with RAS mutation trials that a KRAS example here should be looking at to possibly seek out a trial.
So, I mean, usually these trials they're basket trials that are open to any cancer anywhere in the body that's got that particular mutation. Like you say, this is a drug that targets KRAS, and any tumor anywhere in the body that's got KRAS can enroll in that trial. So, in terms of RAS, I know that RAS, you can get RAS in lung. I'm not intimately familiar with all the areas. I'm so focused in thyroid that I'm not up to date in all the areas where RAS you see RAS tumors, but I know it is a tumor that's seen in a lot of different cancers, and so but I'm not intimately familiar with what those cancers are offhand.
Stephanie, thanks you for that answer. Suzanne online says, if progressing on Retevmo and switching to Caprelsa, but progressing, can you switch back to Retevmo again? Is that an option?
Sure. I mean, why not? I mean, will it work? I don't know. But you could. I mean, I have to be honest here. The chances of that working, I think if a patient has failed Retevmo and then they go on to Caprelsa, and they fail that, I think the chances of going back on the Retevmo and that working well are pretty low, but I mean, you could try it. Yeah.
Thank you. This is probably a good thing to end on. a great comment from an anonymous attendee that I think speaks on behalf of all of us, Doctor. No question here, just a sincere thanks for everything you do for our Medi community.
Yeah.
For our Medi community.
Thanks very much. Thank you.
Oh, and anonymous isn't done. Anonymous still says the work you do is saving lives and improving quality of life, and it's incredibly appreciated.
Thank you. Well, we still have a lot of work to do, so we're working hard every day.
Thank you
So
very much.
thanks, everybody. Yeah.